So let's go now to our last speaker, Professor DAHMANI, who is coming from Paris and who is going to give you an overview of organizational requirement and minimal medical requirements also to anesthetize a child.
Thank you very much. First, before talking about the organization, we will talk first about the patient, and Walid has largely talked about the patient. Of course, we must know what's the patient has of risk of complication. Of course, you have the age of patient, the health condition, and of course also the surgery performance is important to know in order to take care of the patient. However, talking about the patient is talking about half of the question, because there is also the physician. And the physician is important to consider. And pediatric anesthesiologists are usually view from their experience, either as a number of caseload per year, either as a dedicated provider versus an occasional provider, or even as a number of year experience. And many studies have found that the experience of anesthesiologists will decrease the complication. And the problem is, of course, the matching between the patient and the physician. And this is done by organization, and we see that organization will change from one country to another. So when you see the United States, for example, you can provide pediatric anesthesia if you are accredited, and according to those requirements, you can find all the needs or requirements for being pediatric anesthesiologist and accredited in the 28 pages of document that describe all you need in order to be accredited as a pediatric anesthesiologist. And concerning the organization of the care of pediatric patient into surgical pediatric patient, in the United States there is a need for the writing policy between anesthesiologists, between surgeon, and between the institution in order to define the patient to be anesthetized and patient to be operated within each institution. That means there is no regionalization of the care, but rather an arrangement between anesthesiologist and surgeon in order to define patient to be operated. If you're looking to Europe, things are quite different. I give you the example of France, when there is two levels of institution. The first level is level 1, with a dedicated center for pediatric anesthesia, and of course all kind of children are managed within this institution, the tertiary hospitals. And there is a level 2 centers with pediatric anesthesia being performed over 3 years old, like we told before, but they can also perform anesthesia between 1 and 3 years, dependent on their activity and the level and the caseload they perform per year. Of course, we talk about education, European guidelines for training pediatric anesthesia, and Gilles has largely developed this point, and France is following this this statement. So if we have a look to others organizations, they depend on the self-evaluation of competency. Of course, we have no a target number. Of course, it's difficult to define. And about a multidisciplinary discussion between surgeon and anesthesiologist in order to define surgery to be performed within each institution. Of course, material resources are very important, and the appropriate environment like surgical units, pediatrician, high-dependent unit, etc. And finally, depending on the country, you have a regionalization of surgical activity according to those factors. So this is the organization. However, there is another point to consider, is the point of the manpower. So when you look into Australia or United States, there is 21 and 23 anesthesiologists by 100,000 people. But when we look into Europe, things are more heterogeneous, with 15 anesthesiologists per 100,000 people in France, 31 in Germany, and 45 in Switzerland, a rich country, Switzerland. So when we look to the activity of those anesthesiologists, you see that, for example, in Australia, United States, usually anesthesiologists care for the intraoperative and postoperative period, and so they make themselves available for this period. While in Europe, and especially in France, we care for the patient in the preoperative, intraoperative period, postoperative, but also we are intensivist, like we say, and we care for the patient in the united care, in the intensive care unit, but also in a high dependent unit. So the number of physicians available for the intraoperative period and for anesthesia might decrease, and consequently we cannot translate one organization from one country to another. Finally, we also talk about the education, which is very important. Education like classical keeping up to date. Of course, respect of recommendation is very important, and case analysis when complication occur is very important. Simulation is, of course, allowed to training to specific and rare complication, and of course, innovation and research are very important for the knowledge in the field of pediatric anesthesia. Finally, if you want to summarize all the information, we can talk that patient is very important. Assessment of the health state of patient, the surgery performed is important. The physician organization with the experience of anesthesiologist, of course. With the education, it's also important, and the team organization must keep the gears turning in the same direction in order to access or to organize a good practice in pediatric anesthesia and a good quality of care. Thank you very much.
Thank you very much, Souhayl. So, if I have well understood, we have not enough anesthesiologists, especially in pediatric anesthesia.
I should depend on the organization you have. This is very important to consider the organization. That means it's a matching between the patient and the physician, which is important. In my institution, for example, in some cases, one physician is caring for 2 children in the same time in 2 operative rooms. But this is not a problem given that we organize ourselves according to the patient and not. So the organization is very important. When telling there is no enough pediatric anesthesiologist, unfortunately, I have no statistic about. But when looking to the APRICAT study, we found a great heterogeneity between country in the level and the risk of complication. I think that maybe the number of physicians might be involved. I think it's just in our hypothesis. Maybe Walid will talk about, but I think that between one country, one organization to another, that might be play or be involved in the occurrence of complication.
Okay, so regarding the number of anesthesiologists, how can we define the need of anesthesiologists within each department?
Yes, this is a very difficult question. It will depend also on the patient you care for. Of course, if you are doing all patients below 1 year old or neonatal surgery every day, of course you have to organize yourself in order to have one physician with one nurse anesthesiologist specialized in this field and in the operative room. Of course, if you have children with more with health conditions that allow a less aggressive monitoring, in this case you can have less than one anesthesiologist per children. It really depends on what you are doing. Cardiac surgery, for example, you need to have one anesthesiologist in the room and a specialized one. While if you are performing anesthesia in patient over 10 years old, for example, I don't think that we need to have the one anesthesiologist per children.
Okay.
Yes, I think this is a very important question and difficult question, and one should, I agree with you, look at what the case mix you are doing and what is required. Now, if you look at all the given an anesthesiologist somewhere, somehow it's a middle between 600 and 900 cases a year an anesthesiologist is able to, is managing today in Europe. Is it? But again, if you are doing particularly cardiac, You don't do 900 cases, because when you do cardiac, you do 1 case a day, and that's sometimes, you know, it's difficult to do. So, and one important thing that you are facing, we pediatric anesthesiologists, that you are aging. Our demography is aging in Europe. Secondly, we have the on-calls, and the on-calls require to consider this into any system organization. You're thinking about the minimum number that you need to face 24 hours, or to offer 24 hours per 24 hours the service.
Yes.
Also, I would like to point that the minimal number of anesthesiologists required in an institution also depend on whether or not anesthesiologists are involved in the ICU. So it may be a great difference of the number if they are in charge of the pediatric intensive care unit or not.
Absolutely, you're right.
That's what I would pointed during the presentation. Depending on your organization, if you are caring for patient in your intensive care unit, of course, the number will decrease for the intraoperative period and for the preoperative evaluation.
Of course, that's right. And what about the availability of high-dependent unit or intensive care when performing pediatric anesthesia?
I think this is very important to consider in each institution with pediatric anesthesia and surgery, of course, to have at least one point or one place to put patient after surgery when you perform surgery, severe or intense surgery, or you have a patient with comorbidities. It's very important to consider. So depending on the, of course, the situation, you need to have a high dependent unit and intensive care unit. But in specified hospital where there is a level 1, what we term the level 1, this is important to have a high dependent unit in order to monitor per patient after the intervention, especially when there is a problem with the health setting.
Okay. And you said that we have to target the at-risk patient to match with a good anesthesiologist. And how do you do that?
So we're talking we are working in specialized centers. So it's not really the problem, because we are performing currently all kind of anesthesia. The problem is in center where the pediatric activity is not the dominant activity. That means that the physician performing both adult and pediatric anesthesiology. In this case, this is important to target patient with experienced anesthesiology. The problem is what is the meaning of experienced anesthesiology. We see that depending on it depends on the caseload, on the number of your experience. It very depends. But I think that in structures or hospital where the pediatric activity is not the dominant activity, we should have a reference to an experienced anesthesiologist.
Okay, so for the last question, I would like to talk about the neonate, because I have two questions from Aurelia from Madagascar. Hello, Aurelia. What about the neonatal anesthesia? We know that it is more difficult and longer to learn. Yes, to learn. So what do you think about that?
I cannot give you a number of years, a number of cases, a number of hours spent caring for patient, for such a patient. It's the neonatal anesthesiology and surgery must be performed in specialized center. That means that it's the repetition and the training that will acquire you, or you can acquire all the skill in order to perform the anesthesia. But I think that you should have the experience for caring this patient. Now consider what kind of experience. This is very difficult to say.
Okay, so thank you. So I think it's time to conclude now. So I would like to try to summarize the main points that we have seen. So we have to be aware of the incidence of severe adverse event in pediatric anesthesia, and we have to be able to follow these severe events and to discuss this event in our department. And we know that besides this adverse event, we have also other criteria which can be useful to assess quality of anesthesia, and for instance, the feedback of the parents. And also the question is to decrease, of course, the adverse event in pediatric anesthesia. And for that, we have to ensure an appropriate education. And this appropriate education must be based on knowledge acquisition, of course, but also on clinical training in sufficient duration. And also, of course, simulation for the rare critical situations. And if I have well understood, we should manage our team to provide the best care for the best care in the best conditions for the practitioner. And that means, for instance, that the organization should allow to target the at-risk patient for matching him to experimented anesthesiologist. And what we can say is that finally we can, beyond that, we should communicate between pediatric anesthesiologist and favor network of pediatric anesthesiologists for both teaching, of course, and research, of course. Thank you.
Thank you.
Thank you.